back to the basic cardiac ultrasonographic assessment. So let's talk about the actual assessment. We started out with part one where we talked about a quick overview. We talked about the actual views, how to obtain the views, how to judge quality and access and things like that. And now we're going to talk about the actual clinical assessment. So the basic cardiac assessment, basic critical care cardiac assessment, consists of really 5 things. And we're going to talk about these in sequence: LV systolic function, identification for at least severe valvular insufficiency, RV dimensions and RV function, pericardial evaluation, and finally the IVC. So first, the LV function. This is the part of the echo that everyone fixates on because everyone is interested in the LV. Everyone loves the LV. And to be fair, it is an important part of the cardiac evaluation, but there is more to it than the LV, but we'll start by talking about it. So I will start by saying that when it comes to the critical care cardiac ultrasonographic assessment of the LV, forget EF, okay? Ejection fraction is just one of those things that we do not and should not, in my opinion, use as acute care critical care ultrasonographers. And I think there's 2 reasons for that. One is that it takes a very large amount of skill and experience and knowledge to be able to accurately determine by visual parameters the patient's ejection fraction. To put it into perspective, cardiologists have to, in the very least, the last I understand, in the very least interpret 300 formal echoes and perform at least 150 formal echoes in order to meet the minimal qualifications to interpret echoes and to do things like make visual assessments of ejection fraction. But if you want to get really good at it, after 3 years of cardiology fellowship, you do an extra year or 2 of advanced echo training where all you do is read and perform echoes. And at that point, you become really good and really accurate and precise at doing things like visually estimating EF, looking at the echo from multiple views and saying the EF is 35%. And even with all that training, data have shown that the inter-rater variability from one rater to another when it comes to EF is still fairly high. So the bridge to being able to get good at EF is a pretty long one. And I don't think any of us as intensivists should really feel that we will be able to cross that bridge, number 1. Number 2, if you think about it, from an intensivist perspective, from an acute care specialist perspective, the EF is really more of a prognostic number than it is a hemodynamic number, okay? We as intensivists are interested in things like flow and hemodynamics. The EF, even though it may be an approximation of those things, it is not a really, necessarily a really full assessment of hemodynamic function and flow. So forget EF. What you should learn how to do as a critical care ultrasonographer is a qualitative assessment of LV function. And by that, I mean you should know what normal looks like from a qualitative standpoint, know how to identify hyperdynamic LV, and know how to identify a dysfunctional LV. And within dysfunctional, start to get good at differentiating between mild dysfunction, moderate dysfunction, and severe dysfunction. And as we move on to some of the more advanced content, we'll talk about how to assess for things like regional wall motion abnormalities and differentiate between global dysfunction and focal or regional dysfunction. Okay. And as the radiologists say, one view is no view. So get as many views of the heart as possible, get as many of those 6 standard views we just talked about as possible to integrate all the information to get an accurate assessment of qualitative assessment of LV function. So the qualitative assessment of LV function involves the assessment of 2 components: myocardial excursion and myocardial thickening. And you should look at both of those because both of those are equally important. And some would say actually the thickening part of things is probably even more important. But 2 things are there: myocardial excursion, which everyone remembers, and myocardial thickening. So to look at myocardial excursion, there's really 3 parameters that we can look at on the basic assessment side. One is looking at the relative change in LV cavity size. In general, the LV cavity size in systole should be about half the size as it is in diastole. Okay, so cavity size change. The second thing you look at is excursion of the anterior mitral leaflet. In diastole, the anterior leaflet of the mitral valve should look like it's slapping the septum as it opens. okay? And what that suggests is that the atrioventricular pressure gradient is high, making the flow through the atrium to the ventricle great, that pushing the mitral valve up against the septum. All right, and the reason the pressure gradient between left atrium and left ventricle is high is because the left ventricle emptied very effectively before diastole. So that slapping of the anterior leaflet up against the septum is another good analog of LV function or a myocardial excursion in this context. The third thing you look at is you look at the posterior mitral annulus. Don't worry, I'll show you videos of all this. You look at the posterior mitral annulus. That's a place where the posterior mitral leaflet attaches to the heart. And when the LV contracts, that annulus is going to move back and forth. And just kind of qualitatively look at and see how much mitral annular movement you get. Okay, all of these three things are an assessment of myocardial excursion, but that's only half the story. The other half is looking at the actual thickening of the muscle. Okay, because a muscle does two things when it moves, when it's alive. It moves and it thickens. So if you look at each individual wall, no matter what view you're looking at, the thickness of the myocardium in that view, the thickness of the muscle should approximately double in systole when compared with diastole. So you should get approximate doubling in muscle thickening in systole. Okay, and you want to look at each individual wall and make sure all the walls in your view are doing thickening as effectively as possible, about doubling in thickness. Okay, so again, excursion, which includes cavity size change, anterior mitral leaflet excursion, and posterior annular mitral annular movement. And then you look at thickening of the muscle. It should almost double in thickness. So that's your qualitative assessment of LV function. And when we, just to get into some terminology, if a muscle is not moving or thickening as much as it should, though it may be moving and thickening, just not as much as it should, you would call that a hypokinetic muscle or a hypokinetic chamber. If the muscle is not moving at all, it's not moving, it's not thickening, then that's called akinesis of that muscle or of that wall. If the wall is moving in the wrong direction and not thickening, that's called dyskinesis. And what that suggests is the other walls around it are alive and moving. And as they contract, it's actually pushing the dead wall back in the other direction. So dyskinesis is paradoxic movement of that wall. And finally, you get aneurysm, where the muscle itself is thinned out, and you have a aneurysmal sort of formation. So hypokinesis, akinesis, dyskinesis, aneurysm. These terms become more and more important when you start looking at regional wall motion abnormalities. But when you're doing a global qualitative assessment, you should say things like the LV function is normal, or there's severe global LV dysfunction, or there is a hyperdynamic LV. That's how you should report your LV function. I do not want to hear the EF looks good. I'll make you say it again. Okay, so that's again your global assessment. And when we move on to looking at regional wall motion abnormalities and how to assess for that, we will talk about how to tie in regional wall motion assessment to your LV function. Okay, so here is a normal peristernal long again. And if we look at, this is a normal LV function. And if we break it down, we can look at all the components. So remember, we said excursion and thickening. With an excursion itself, there's three components. There is cavity size change. So you can see the cavity is getting about half the size in systole as it was in diastole. You can see that the anterior leaflet of the mitral valve is slapping up against the septum when it opens. And here is the posterior mitral annulus. So this is where the posterior leaflet of the mitral valve attaches to the heart here. That connective tissue structure is the mitral annulus. And notice how that's moving left and right. Okay, so cavity size is changing by about half. The anterior leaflet of the mitral valve is slapping the septum, and the posterior mitral annulus is moving vigorously left and right. So that's normal excursion. Okay, the second thing, don't forget, thickening. So if you look at the septum here, you can see that the thickness of that septum is approximately doubling in systole versus in diastole. Same thing with the free wall here. This is the infralateral free wall. You can see that the muscle there is almost doubling in thickness in systole versus diastole. Okay, so normal excursion, normal thickening, normal LV function. Same thing with your short axis view. Again, normal peristernal short. You can see that all of the walls are moving and thickening. I still do this. I will put my finger in the middle, and I want all those walls to move and thicken towards my finger in systole and move out in diastole. So that's normal excursion, normal thickening, normal LV function. Here is a not so subtly dysfunctional LV. Let's break it down. Excursion. First thing you look at in excursion, cavity size change. That cavity size is not getting about half its size in systole versus diastole. It's not really changing all that much at all. The mitral annulus, I'm sorry, the anterior leaflet of the mitral valve is not even coming close to slapping the septum. And the posterior annulus of the mitral valve is moving, just not as vigorously as you're used to. So bad excursion. If you look at thickening, there is really no thickening there of that septum. And there's some thickening of the infralateral wall, but it's not quite doubling in thickness. Okay, so I would call this severe global LV dysfunction. We'll ignore, there's some degree of regional wall motion there, but we'll ignore that for now. Short axis view, same thing. If you put your finger in the middle there, those walls are not coming anywhere close to thickening and moving in towards your finger. Okay, so severe global LV dysfunction. Here's the other side of the spectrum. You can see this is a peristernal long axis view. You can see that in the end of systole, the septum and the infralateral wall appear to be touching. This is called end systolic effacement of the LV, suggesting a hyperdynamic LV function. If you see this with someone in shock, they need fluid. Okay, so hyperdynamic LV in the setting of shock, that means volume responsive shock state. Okay, end systolic effacement. The next thing you look at is valvular insufficiency. And so our job as intensivists is to identify evidence of severe valve insufficiency, because it's severe valve insufficiency that's going to contribute significantly to your shock state or cause your shock state. Okay, I will preface this by saying that the assessment for valvular insufficiency, valvular regurgitation, is a complex one. It takes several steps, applying various color and quantitative Doppler techniques and various measurements and things like that. So it is a very involved process. What we do is a very quick and dirty assessment. And so it is, I will admit, a very incomplete assessment for valve insufficiency, for severe valve insufficiency. Okay, so what you would do in general is you would do this, put color over the valves. If you see something that looks concerning for severe valve insufficiency based on what I'm telling you, order a formal echo. Okay, but while the formal echo is pending, you can start your interventions based on the assumption that you have a shock state with a severely insufficient valve. Okay, so what we do, quick and dirty assessment from the critical care side, is that we take color and we put color over the receiving chamber of the regurgitant flow. So if we're talking about mitral regurg, we put color Doppler over the left atrium. So the left atrium is going to receive the mitral regurg. And we want to see if there is a color signal that is originating at the mitral valve and shooting into the left atrium in systole. Okay, so you want that color window to encompass the atrial side of the valve and the entire left atrium. Because what you want to judge is, if you're seeing color shooting from the left ventricle into the left atrium, and that color jet is filling more than 50% of the left atrium, then that is a clue that you may be dealing with severe valve insufficiency. Okay. Similar judgment with an aortic regurg. You're going to put your color window over the left ventricular outflow tract, which is the chamber that receives the aortic regurg. And you want to sample the aortic valve and the LVOT with their color window. If there is a color jet shooting from the proximal aorta into the LVOT in diastole, and that color jet fills more than 50% of the diameter of the LVOT, then that is concerning for severe aortic regurg. Okay? But if you see something like this or something that's approaching this, order a formal echo, because this is a complicated evaluation as a whole. Okay. So severe valve insufficiency, quick and dirty assessment. This is our job here. Our job is not to identify these things, the things that can cause severe valve insufficiency, but we can look. We can look at the valve, we can zoom in on the valve and see if we see something that may look like a vegetation or may look like, you know, a flail leaflet tip or something like that. Again, formal echo is the assessment for that piece. But if we see what looks like maybe a vegetation in a patient who is looking bacteremic, looking septic, is decompensating, you know, you may want to, you know, start intervention for that until you get your formal echo. Okay. The best views to assess these things are your peritoneal long for the mitral and aortic valves, and the apical 4 and 5 chambers for the mitral and aortic valves. So here's an example of severe mitral regurg. What we're looking at here is a peritoneal long axis view. There is the left ventricle here. There's the left atrium, the mitral valve. We have our color window here. And notice that it is encompassing the entire mitral valve and the entire left atrium. Okay, I will show you at the bedside how to adjust the size and position of that color window. But you want to make it the same size as the left atrium. And you can see here that in systole, when that mitral valve is closed, or when that aortic valve is open, when that aortic valve is open, there's a color jet shooting into the left atrium. And it's clearly filling more than 50% of the left atrium. So this is very concerning for severe aortic regurg. Just for fun, we zoomed in on the valve to see if there was something structural going on. And this is a flail leaflet tip. You can see the posterior mitral valve is flailed here because of a ruptured chordate. Again, not our job, but if you see it, it's cool, and you can pass that information on to your, you know, your cardiology consultant or your echo tech. Here is an example of aortic regurg. This is a little bit tougher to see because this color window is a little bit too big, but what we're looking at here is a color jet starting at the proximal aorta here and shooting into the LVOT in diastole. So when the mitral valve is open, that color jet is shooting in there, and it is clearly encompassing more than half of the diameter of the LVOT. So this is very concerning for severe aortic regurg. Okay, the next thing we look at is the RV. And there's really two sort of components to the RV evaluation. The first is looking at RV dimensions, and that is to get an idea of whether there is evidence of RV pressure or volume overload. Okay, the two components to look at for your RV dimensions, the first is RV size. And what we're trying to do essentially is we're trying to compare the size of the RV to the size of the LV. To do that, we look at the base of each chamber. We're doing this in the apical 4 chamber. So remember, the apical 4 chamber view is the only view where you can accurately and fully assess RV size. So you're going to get your on-axis. It's very important to be an on-axis apical 4 chamber view. And you're going to essentially look at the diameter of the base of the RV versus the diameter of the base of the LV. And that diameter should be smaller. The RV diameter should be smaller than the LV diameter. They talk about a ratio like a 1/3, 2/3 ratio or a 40/60 ratio of RV to LV. That's all well and good. But if you have someone who's on positive pressure, who has all kinds of other stuff going on, RV smaller than LV is what you're going for. Okay. If the RV is the same size or bigger than the LV, then it is dilated. Okay. The other thing you look at is septal shape and septal motion. And remember, the peritoneal short axis view is the best view, or the subcostal short axis view is the best view to look at this. Okay. So what you want the septum to do is you want the septum to be convex in shape, and you want that convexity of the septum to be pointing up towards the RV. Okay. And the result will be a round shaped LV. And when the septum moves, you want it to be moving concordantly with the rest of the LV, such that the septum belongs to the LV. So when the LV is in systole, the septum is moving down into the LV. When the LV is in diastole, you want the septum to be moving out. Okay. Abnormal septal shape is when it's flat or actually bowing into the LV, creating a D shape of the LV. Abnormal motion is when the septum is either bouncing or is completely moving discordantly with the LV free wall. Okay. These things, dilated RV, septal flattening, septal discordance, all these things would suggest RV pressure / volume overload. Okay. If the septal abnormalities are predominantly or actually only in diastole, then likely what you're dealing with is a volume overload type situation. If the septal flattening and dyskinesis are both in systole and diastole, it is a pressure overload phenomenon, most likely. They're not mutually exclusive necessarily, but it sort of points you in one direction or the other. The second part of the RV assessment is RV systolic function. And the easiest way to assess RV systolic function is looking at what's called the TAPSE. So TAPSE is the tricuspid annular plane systolic excursion, which basically means how much apical movement there is of the tricuspid annulus. So what happens when the RV contracts is that the primary plane in which the RV chamber gets smaller is by shortening of the RV. And so when the RV shortens, what happens is the tricuspid annulus moves up and down. So in systole, when the RV is shortening, the tricuspid annulus moves up towards the apex. And in diastole, when it's filling, it moves down. So measuring the degree of annular movement up towards the apex in systole can get you a pretty good assessment of how well the RV is contracting. This is best done in the apical four-chamber view. You can do it in some of the other modified views, but the apical four-chamber view is your standard view. Normal annular movement is anywhere between like 1.6 to 2.2 centimeters. Under 1.6 is considered RV dysfunction. So here is an example of tricuspid annular movement. You can see that as the RV is contracting in systole, that annulus is moving up. So you can either eyeball that and see, is this movement at least 1.5 centimeters? You can sort of correlate it with the centimeter markers over here. Or you can use M mode. You would turn on M mode and put your M mode line down through the tricuspid annulus, trying to, as your best to line up the motion of the tricuspid annulus to be as parallel to the M mode line as possible. And this is what that would look like. So in your apical four-chamber view, you turn on your M mode, put the M mode line down through your tricuspid annulus, and you will get something that looks like this. So if you look at all the structure that the M mode line is going through, it's going through the LV apex first, then the LV chamber, then the septum, then the RV chamber, and then finally through the tricuspid annulus. So all these lines here, we're looking at movement of these structures over time. So here is the LV apex, the LV chamber, the septum, the RV chamber, and your tricuspid annulus. And you can see that over time, on the x-axis, that tricuspid annulus is moving up and down. And if you put a caliper from here to here, it will give you the vertical distance. That is to say how much motion there is over time. Okay? So this is what normal looks like. This is what RV dysfunction looks like. TAPSE of 2.2, TAPSE of 0.8. Okay? The concept of RV strain or Cor Pulmonale is sort of a constellation of findings. It's a combination of a dilated RV with abnormal septal shape and septal motion and RV systolic dysfunction. The sort of extreme of that is what's called McConnell sign. I will show you a picture of that or a video of that. And remember your differential diagnosis for acute RV strain. Okay. So here is normal septal shape and motion. You can see that the septum is convex, convexly pointed to the RV. You can see that the septum moves in towards the LV in systole. It moves out away from the LV in diastole. Normal RV size and function. You can see that the diameter here at the base of the RV is much smaller than the diameter here at the base of the LV. And again, the tricuspid annular systolic excursion is pretty good. Here's abnormal septal shape. You can see the septum is flat. And you can see that it's moving paradoxically. It's moving up towards the RV during systole and down into the LV and diastole. So this is both septal flattening and septal paradox, septal disconus. And here's an example of RV dilation. No, the dot is not switched. This is the RV. It's huge. The diameter is much larger than the LV diameter. So this is RV dilation. And if you looked at this TAPSE, that annular motion is not great. If you did a M-mode analysis of that, it would be probably under 1. So this is a dilated and hypokinetic RV. The extreme of that is what's called McConnell sign. So McConnell sign is essentially where you have an RV that is grossly dilated and dead. So it's hypokinetic and dilated, except for the apex here. So the apex of the RV is the only part of the RV that's functioning. Okay. In general, RV dilation and RV dysfunction starts at the base and moves up towards the apex. So essentially, the entire RV here is not working except for the apex. The next step after this is cardiac arrest. So this is almost like end-stage Cor Pulmonale or end-stage RV strain. It was thought initially that McConnell sign was specific for pulmonary embolism, but it turns out that anything that can cause either an acute or even a subacute chronic rise in RV afterload can cause McConnell sign. So it's not necessarily specific for PE. Okay, but if you see this, it indicates that there is a significant an end stage amount of RV pressure overload resulting in RV dysfunction as well. Okay. Next, you look at the pericardium. I do have a separate lecture on pericardial tamponade. So that is a sort of a focused talk, but I'll talk about sort of the basic pericardial assessment. So typically, tamponade will be the result of a pericardial effusion. But remember, other things can cause tamponade. Things that are outside the heart can cause tamponade. So mediastinal masses, mediastinal hemorrhage, all these things can cause tamponade physiology. So just because you don't have a pericardial effusion does not mean you cannot have tamponade. Okay? So anything external to the heart can cause compression on the chambers and force the extracardiac pressures to exceed the intrachamber pressures in diastole, which is what tamponade is. Okay? The tamponade physiology on echo is really two things, at least on the basic assessment. The most specific indicator of tamponade on echo is diastolic collapse of the right ventricle. So in other words, when the RV is supposed to be filling in diastole, the pressures outside of the heart, either within the pericardium or outside the heart altogether, exceed the pressures in the RV chamber. And the result is collapse of the RV when it's supposed to be filling. So it's the most specific echo indicator of tamponade is diastolic collapse of the RV. More specifically, early diastolic collapse of the RV OT. Okay? Occurring earlier in the course of tamponade, so more sensitive but less specific than diastolic RV collapse, is right atrial collapse during ventricular systole. So remember, the right atrium fills during ventricular systole. So when it's supposed to be filling, it's actually collapsing. So that's more sensitive for tamponade, but less specific. Other things can cause it to happen. Okay. Here's an example of diastolic collapse of the RV. Turns out the peritoneal long axis view is actually a really good view to assess for tamponade physiology, to assess for diastolic collapse of the RV. And the reason for that is, like I mentioned, the RV OT is the part of the RV that's most susceptible to collapse. The peritoneal long axis view is one of the views where you get a really good visualization of the RV outflow tract. So what you're seeing here is a peritoneal long axis view, a large pericardial effusion, okay? And it looks like someone is standing on top of the RV OT and jumping on it like on a trampoline, okay? So that's RV collapse. You can have RV collapse for one of two reasons, right? It can either be in systole, which would indicate just a hyperdynamic RV, or it could happen in diastole, which would indicate tamponade. So your goal here, your job here is to identify, is this collapse occurring in systole or is it occurring in diastole? If you have an EKG tracing, you can use that to help you determine when there is systole or diastole, so QRS versus the T wave. If you don't have EKG tracing, which will probably be most of the time for point of care echo, the best way to determine systole versus diastole is to look at the valves. So looking at the mitral valve, diastole is when the mitral valve is open, and systole is when the mitral valve is closed. So the question you're asking yourself is that RVOT collapsing when the mitral valve is open? And it can be tough to assess that. Quite fortuitously, this video froze when the RV is collapsing. And you can see clearly that's happening when the mitral valve is open. So the way you can, it's tough to look at two things at the same time. So the way you can do this is you can either get a video and slow it down and go frame by frame, or you can use M mode. And on the tamponade talk, I show you how you can use M mode. But what you would basically do is you would take your M mode line and put it down through the RVOT and down through your mitral valve. And what you'll be able to see is you'll be able to look at what each structure is doing simultaneously. Okay. So that's diastolic collapse of the RV. Here's an example of systolic collapse of the RA. You can see that this is the apical four-chamber view. And the RA here, you can see is sort of involuted. It looks like someone's lying on their back and kicking the right atrium here in. So involution of the right atrium here. And it looks to be correlating with when the LV here is contracting or when the tricuspid annulus is rising, suggesting systole. Okay? So that tricuspid annulus is being kicked up, so is the wall of that right atrium. So this is systolic collapse of the right atrium, suggesting early tamponade. Of course, you have a large pericardial effusion there as the etiology. The last thing we look at is the IVC. I will say that the IVC is a source of a lot of consternation, both with students of ultrasound and teachers of ultrasound. So I will say that one of the things that annoys me the most that I overhear on rounds or in the ICU at any given time is from a resident or an intern, I want to figure out this patient's volume status. Let's look at the IVC. Okay. The IVC, and that's just wrong. The IVC is not the panacea for determining volume status or volume responsiveness, which is really what we're trying to get at. Okay. It is not a black and white. In fact, there's really only 3 situations where the IVC assessment will give you a reliable indicator of whether a patient's going to respond to volume. Okay. And those things are right here. Every other situation, the IVC is not entirely helpful. Okay. The one situation is, situation number 1, patient's in shock and the IVC is flat. If you have a flat IVC in someone who's in shock, whether they're on positive pressure or negative pressure, it's a flat IVC and they're in shock, they will very likely be volume responsive. Okay. So a small IVC is helpful. A big IVC doesn't necessarily mean anything. Okay. An IVC diameter greater than 2.5 or whatever your arbitrary cutoff is does not necessarily mean that the patient is not going to respond to volume. Okay. But if the IVC is small, that's helpful. The second thing you look at is respiratory variation. There's 2 situations where respiratory variation is helpful. One is looking at in your patient who is spontaneously breathing negative pressure and who is cooperative. If you look at that patient's IVC and the IVC collapses by more than 50% when you make them do a forced inspiration or a sniff and they're in shock, they're very likely to be volume responsive. So 50% inspiratory collapse, forced inspiratory collapse of the IVC, they're likely volume responsive. What this is getting at is that their right atrial pressure is low. So if you have a low right atrial pressure, say what you want about CVP, but if your CVP is low and you're in shock, give fluid. The second scenario is the patient who's on the ventilator, invasive mechanical ventilation. Okay, they will have respiratory variation, or in this case, what's called respiratory distensibility of the IVC by more than 18 to 20%. So what that means is when the vent cycles into inspiration, the IVC distends by at least 18%. And in that patient, they're likely to be volume responsive. But that is only if they meet all four of these criteria. One, they have to be passive on the vent, so they cannot be triggering the vent, at least not consistently. Number two, they should at least be on 8 cc's per kilo ideal body weight tidal volume. There are some studies that a couple studies that looked at patients who have poor lung compliance who are on 6 cc's per kilo, but most of the studies, the patients are on 8 cc's per kilo ideal body weight tidal volume. They have to be in a regular cardiac rhythm, and they have to have a normal RV. So in any given time in my ICU, there's probably one patient out of 22 that meet these criteria. Okay, and that's a patient who's paralyzed, for severe ARDS or something like that. Okay, so not a whole lot of patients meet these criteria. But for example, if you've just intubated someone and you used a long-acting paralytic on them, you can use this. If someone's paralyzed, in the ICU for some other reason, you can use this as well. But otherwise, not a whole lot of applicability. And overall, the IVC itself is not going to give you the answer. Okay, I have another talk on volume responsiveness where I'll get into the weeds of all the various methods. But just know that the IVC is not a panacea, and there's more gray area than there is black and white. Okay, here's an example of a virtual or a flat IVC. You can have you see the liver here, and this potential space here is your IVC. So if you see this and someone's in shock, they're very likely to respond to volume. Here's a dilated IVC. You can see the IVC is quite large. You can also see the descending aorta here. And again, we talked about the three things you look at to determine IVC versus aorta. One, cavoatrial junction. Two, you can sort of see the inlet of the hepatic vein right here. And three, you can see the IVC going through the liver. The aorta does none of those things. Okay. So that is the basic cardiac assessment when it comes to critical care ultrasonography. Okay, and this table, if you're a fan, this is sort of a version of the classic, PA catheter finding and type of shock table that there is in every critical care textbook that's out there, but it's adapted for ultrasound. So what we have here is what you can see on the LV, the RV, and the IVC, at least classically in each of the various types of shock. So if you're a fan of this kind of table, I think this is helpful. But this is just to sort of summarize all the various findings and how they correlate with the 4 subtypes of shock that we opened up the talk with. Okay, so as usual, if you have questions, come find me or shoot me an email, and I look forward to scanning with you.